Some children, at first, simply seem hard to manage. You call their name and they seem not to hear you. Their gaze drifts away. They rarely make eye contact. Their language develops slowly. They say very little. They cannot sit still. They never seem to stop moving. Their temper flares at the slightest trigger. They may suddenly bang their head, hit their head, bite their hands, or burst into tears. Their sleep is broken throughout the night. Then, during the day, they are intensely irritable. Many parents initially hear one of these explanations. Maybe it is autism. Maybe it is attention deficit/hyperactivity disorder, or ADHD. Maybe it is an emotional problem. Maybe it is a behavioral problem. But then, new problems begin to appear. Headaches, vomiting, sensitivity to light, sensitivity to sound, seizures, staring spells, abnormal eye movements, unsteady walking. Suddenly, the picture becomes far more complicated. The headaches are managed by neurology, the emotional symptoms by psychiatry, the developmental concerns by developmental behavioral pediatrics, the seizures by an epilepsy specialist. Every problem seems to have its own specialist, but one group of disorders is especially easy to miss during this process. Inborn errors of metabolism, or IEMs. IEMs do not necessarily look like rare diseases at first. They do not always arrive looking like rare disorders. They may wear a different mask. They may look like autistic features, like hyperactivity, like behavioral dysregulation, like migraine, like epilepsy, or even like psychiatric symptoms. All while the underlying disorder remains quietly hidden in the child's brain. So the true warning sign is not any one symptom. It is the pattern behind the symptoms. If a child's autistic-like features, behavioral problems, migraines, or seizures cannot be explained by a clear acquired or external cause, if the symptoms come in episodes, if they improve and then worsen again, if the child begins to lose previously acquired abilities, or if several body systems are involved at the same time, then the evaluation cannot stop with the statement, "This is just a behavioral problem related to autism." IEMs should also be included in the differential diagnosis. Chapter 1. Rule out acquired causes first. But do not let that be the end of the evaluation. Some IEMs really can look remarkably similar to autism spectrum disorder, or ASD. But there is one crucial distinction. ASD is a clinical diagnostic framework. IEMs, by contrast, are biological disorders that may affect brain development and the function of brain networks. They are not the same thing. But in some children, they can overlap. A child may genuinely meet the diagnostic criteria for ASD. At the same time, that child may also have an underlying inherited metabolic disorder. If doctors and parents see only the ASD label and never ask one more question, why is this happening? They may miss conditions that can be treated, conditions for which outcomes may be improved, or conditions that would at least change emergency management and medication choices. Of course, this does not mean that every child with autistic-like features should immediately be suspected of having an IEM. The first clinical step is still to look for other causes. Has the child had a head injury? Was there hypoxia, a near-drowning event, birth trauma, or a traffic accident? Any of these can cause brain injury, and that injury may leave behind mood instability, poor impulse control, memory decline, or abnormal behavior. Doctors must also look for infection, meningitis, encephalitis, a brain abscess. These conditions may cause fever, altered mental status, delirium, seizures, or even psychotic-like symptoms. Immune-related disorders must also be considered. Autoimmune encephalitis. Multiple sclerosis. When the immune system attacks the nervous system, it can affect cognition, mood, behavior, and level of consciousness. Then there are brain tumors. A tumor may compress brain tissue. It may disrupt brain networks, or it may alter intracranial pressure. This can lead to headaches, seizures, personality changes, hallucinations, and cognitive decline. Certain endocrine disorders or tumors that disrupt metabolism may also affect brain function through hypoglycemia, electrolyte disturbances, or hormonal abnormalities. Medications, alcohol, illicit drugs, heavy metals, and industrial toxins can also directly disrupt neurotransmission and brain function. These are all causes that doctors need to investigate. But if none of them fully explains the child's symptoms and the child shows a clear pattern of red flags, do not let the evaluation end with, "This is just autism. This is just a behavioral problem." Because sometimes behavior is only the surface. The real disturbance may lie in the metabolic environment inside the brain. Chapter 2. Why can IEMs look like autism, psychiatric symptoms, migraine, or epilepsy? Because the brain is not a machine that runs on psychology alone. It is more like a high-energy city. To keep that city running smoothly, it needs power. It needs fuel. It needs traffic signals. It needs a system for clearing away waste. And it needs its roads and communication networks to remain open. Different regions of the brain support different functions. The frontal lobes are involved in planning, judgment, impulse control, and social behavior. The temporal lobes are involved in language, memory, and auditory processing. They are also associated with certain hallucinations, déjà vu, and seizures with emotional symptoms. The limbic system is involved in fear, emotion, reward, and the assessment of threats. The basal ganglia help regulate movement, motivation, and habitual actions. The cerebellum does more than control balance. It also contributes to language, cognition, and emotional regulation. The brainstem and autonomic nervous system networks influence sleep, breathing, heart rate, alertness, nausea, vomiting, and pain regulation. But no single brain region on its own determines one specific psychiatric symptom. What truly matters is the entire brain network. And for that network to function reliably, several conditions must be met. There must be enough energy. The mitochondria must be able to generate power. Neurotransmitters must be synthesized, released, and cleared normally. Ammonia, lactate, organic acids, and abnormal amino acid levels cannot be allowed to chronically injure neurons. Cofactors such as vitamin B6, vitamin B12, tetrahydrobiopterin, or BH4, 5-methyl-tetrahydrofolate, or 5-MTHF, thiamine, biotin, and folate must be available for enzyme reactions. The balance between excitation and inhibition, including glutamate and gamma-aminobutyric acid, or GABA, must remain stable. White matter, myelin, cell membranes, and connections across brain networks must also remain intact and stable. If one metabolic pathway becomes blocked, the brain may not shut down immediately. More often, it first becomes unstable. A child may have trouble paying attention, their mood may become unstable, their sleep may fall apart, they may develop recurrent headaches, brain fog, anxiety, depression, hyperactivity, autistic-like features. Their learning may regress, they may use less language, they may respond less when their name is called, they may even develop seizures, abnormal movements, hallucinations, delusions, agitation, or aggressive behavior. You can think of it as a chemical traffic accident inside the brain. Some roads carry fuel. Glucose cannot be used properly. Fatty acid oxidation becomes impaired. The mitochondria cannot generate enough power. Other roads handle detoxification. Ammonia is not cleared. Organic acids accumulate. Lactate rises. Some roads carry signals. The synthesis, release, or clearance of dopamine, serotonin, GABA, and glutamate may become disrupted. Other roads depend on cofactors. If 5-MTHF-BH4, pyridoxal 5' phosphate, or PLP, vitamin B12, or folate are insufficient, an entire chain of enzyme reactions may slow down. And some roads support cell membranes and myelin. Abnormal metabolism involving N-acetylaspartate, or NAA, choline, myoinositol, or lipids may affect white matter and connections across brain networks. These abnormalities do not always present as a severe metabolic crisis. They may first appear as psychiatric, neurologic, or behavioral problems. That is why some IEMs, especially late-onset IEMs, may show few obvious physical signs during adolescence or adulthood, while psychiatric symptoms become much more prominent. And that is also why care can become fragmented across psychiatry, neurology, and developmental behavioral pediatrics. Each symptom is managed separately, but no one recognizes that they may all belong to the same underlying pattern. So psychiatric symptoms are not the final answer. Behavioral problems are not the final answer. Autistic-like features are not necessarily just another label. Sometimes they are the signals that rise to the surface when the chemical environment inside the brain has fallen out of balance. Chapter 3. Which IEMs can look like autism? Different inborn errors of metabolism, or IEMs, can affect a child's brain in different ways. They may push the brain toward autistic-like features, epilepsy, migraine, behavioral abnormalities, or even psychiatric symptoms. At first, these problems may appear to be scattered across different medical specialties. But sometimes the same kind of problem lies beneath them all. A metabolic pathway in the brain has stopped working properly. The first is glycine encephalopathy, or GE. It is also known as non-ketotic hyperglycinemia, or NKH. In this disorder, the glycine cleavage system does not work properly. As a result, glycine rises abnormally in the blood and cerebrospinal fluid, or CSF. Glycine is not an ordinary amino acid. In the brainstem and spinal cord, it acts like a brake. But in the N-methyl-D-aspartate receptor system, or NMDA receptor system, of the cerebral cortex, glycine can also act like an accelerator. So, when glycine levels become too high, the brain may be pulled in two directions at once. On one side, slowed responses, low muscle tone, and on the other, a greater tendency to develop seizures. Disrupted sleep, explosive emotional outbursts, impulsive behavior. That is why children with attenuated NKH do not always present with the classic severe form at birth. Their symptoms may appear later. Delayed language development, autistic-like difficulties with social interaction, a reduced response when their name is called, hyperactivity and impulsivity, aggressive behavior, fragmented sleep, seizures, abnormalities on an electroencephalogram or EEG, and sometimes involuntary movements. The second is thiamine metabolism dysfunction syndrome (PHI) or THMD5. It is caused by TPK1 deficiency. This is not simply a matter of getting too little vitamin B1 from the diet. The problem is that once vitamin B1 enters the body, it cannot be efficiently converted into the coenzyme the brain actually needs. That coenzyme is called thiamine pyrophosphate, or TPP. TPP is an essential tool for many enzymes involved in energy metabolism. This disorder can be remarkably deceptive. At first, a child may appear to have encephalitis. Later, the presentation may look more like autism, a fever, an infection, dehydration, or another form of physiologic stress. Any of these may cause the child to suddenly become agitated, restless, or intensely irritable. The child may use less language. Eye contact may decrease. They may refuse to walk. They may stop participating in everyday activities. Their gait may become wide-based. They may become unsteady on their feet. Their mental status may also change. Then, over the next 2 or 3 weeks, some function may gradually return. This pattern, regression after an illness, partial recovery, and then another episode, is different from a relatively stable ASD presentation. It is more like the brain losing power again and again whenever the body is under stress. THMD5 is also a treatable IEM. In some patients, ASD features may improve substantially after treatment. The third is glucose transporter type 1 deficiency syndrome, or GLUT1DS. This is an SLC2A1 related disorder. The problem is not that there is no glucose in the blood. The problem is that glucose cannot enter the brain effectively. When glucose levels in the CSF remain chronically low, the brain stays in a low-fuel state. Some children may not look like they have a classic metabolic disorder at first. Instead, they may appear to have developmental delay, delayed language, learning difficulties, poor attention, difficulty with social communication, repetitive or rigid behavior, epilepsy, episodes of abnormal eye and head movements, unsteady walking after exercise, abnormal muscle tone, and symptoms that worsen with fasting, fatigue, fever, or physical activity. In many cases, the first visible sign of GLUT1DS is not a convulsive seizure. Instead, the child may look as though they have autism, hyperactivity, or developmental delay. The cornerstone of treatment is often ketogenic diet therapy. Ketone bodies can serve as an alternative fuel for the brain, and that treatment approach directly matches the mechanism of the disease. The fourth group includes serine biosynthesis defects. These disorders may involve the PHGDH, PSAT1, or PSPH genes. Serine is more than a routine nutrient. It is an important building block the brain uses to produce membrane lipids, sphingolipids, D-serine, and glycine. It is also important for one-carbon metabolism. All of these functions are critical for brain development. Some patients with milder or juvenile onset forms do not have severe symptoms at birth. Instead, problems may gradually emerge. Learning difficulties, mild to moderate intellectual disability, developmental delay, absence seizures, attention problems, behavioral problems, mood instability. These symptoms are extremely common, so they can easily be attributed to developmental delay, ADHD, the autism spectrum, or even normal teenage defiance. But serine biosynthesis defects are treatable neurometabolic disorders. L-serine supplementation is central to treatment. The earlier the disorder is recognized, the greater the opportunity to reduce neurologic injury. So when autistic-like features appear together with absence seizures, learning difficulties, and behavioral problems, do not forget to consider amino acid testing in plasma and CSF, even if brain magnetic resonance imaging, or MRI, appears normal. The fifth is biotinidase deficiency, or BD. This is a disorder of vitamin metabolism. The body cannot efficiently recycle biotin. As a result, multiple biotin-dependent carboxylase enzymes cannot function properly. Fatty acid synthesis is affected. Amino acid breakdown is affected. And gluconeogenesis is affected. Untreated profound BD commonly causes seizures, low muscle tone, ataxia, developmental delay, It may also cause skin rashes, hair loss, hearing problems, or vision problems. But some children do not look typical at first. They may develop episodic gait abnormalities, language regression, declining attention and memory, reduced social interaction, hallucinations or other perceptual disturbances, excessive sleepiness, and in severe cases, even coma. If these symptoms are mistaken for a purely psychiatric problem, the opportunity for timely biotin treatment may be missed. The sixth is aromatic L-amino acid decarboxylase deficiency, or AADC deficiency. This disorder is caused by defects in the DDC gene. It disrupts the synthesis of dopamine and serotonin. It also affects the pathways that produce epinephrine and norepinephrine. This is not simply a movement disorder, and it is not simply a developmental disorder. A critical step in the brain's neurotransmitter production line has become blocked. Typical features include low muscle tone, oculogeric crises, developmental delay, dystonia, and autonomic symptoms, but milder cases are much easier to miss. A child may initially have delayed language, poor attention, easy fatigability, an existing ASD diagnosis, or autistic-like features. The eyes may suddenly roll upward, even though the EEG may be normal. The child may develop abnormal twisting postures after exercise. Symptoms may become more noticeable later in the day. There may also be nasal congestion, low muscle tone, and autonomic dysfunction. So, if a child who appears to have ASD or ADHD also has oculogeric crises, exercise-induced abnormal posturing, symptoms that worsen toward evening, nasal congestion, and low muscle tone, the evaluation needs to move beyond a behavioral diagnosis. Neurotransmitter metabolism disorders should also be considered. The seventh is aspartyl glucosaminuria, or AGU. AGU is a lysosomal storage disorder caused by defects in the AGA gene. In this disorder, glycoproteins cannot be broken down properly. Undegraded material accumulates inside cells. Over time, this may affect the white matter, the thalamus, subcortical circuits, and connections across the brain. During childhood, AGU may not look like a severe rare disorder. Instead, the child may have delayed language, clumsy movements, hyperactivity, poor attention, a limited social response, reduced eye contact, repetitive behavior, and restless sleep. That is why some patients may initially be viewed as having ADHD or ASD. The eighth is phenylalanine hydroxylase deficiency, or PAH deficiency. It is commonly known as phenylketonuria, or PKU. This is one of the most classic examples of the connection between IEMs and neurodevelopment. Without newborn screening and timely treatment, phenylalanine can rise in both the blood and the brain. Over time, this may cause irreversible cognitive impairment, seizures, movement abnormalities, behavioral problems, and psychiatric symptoms. Patients who are diagnosed late or remain untreated may also develop neurocognitive impairment, movement disorders, epilepsy, microcephaly, and behavioral problems. The importance of PKU goes far beyond the name of the disease. It teaches us something critical. In the same child, a brain that remains in the wrong metabolic environment for too long may follow a very different neurodevelopmental path. But if the condition is detected through newborn screening and dietary treatment begins early, the outcome may be completely different. This is the medical logic at the heart of the discussion about IEMs and ASD. Some neurodevelopmental and behavioral features are not simply labels. They may be metabolic consequences that can be traced, measured, and potentially addressed with treatment. The ninth group is creatine deficiency disorders, or CDDs. These include guanidinoacetate methyltransferase deficiency, or GAMT deficiency, L-arginine glycine amidinotransferase A deficiency, or AGAT deficiency, and creatine transporter deficiency. The creatine system works like an energy buffering battery for the brain. It helps nerve cells mobilize energy quickly. When that system fails, a child may develop developmental delay, cognitive impairment, intellectual disability, and speech-language impairment. GAMT deficiency also commonly involves epilepsy and behavioral problems. These may include hyperactivity, autistic-like behavior, or self-injurious behavior. At first, these children may appear to have delayed language, autistic-like social difficulties, hyperactivity, behavioral problems, epilepsy, or abnormalities of movement and muscle tone. The clues in this case are often found in guanidinoacetate levels in urine and blood, creatine and creatinine-related markers, the creatine peak on brain magnetic resonance spectroscopy, or MRS, and relevant genetic testing. So the combination of delayed language, autistic-like features, and epilepsy does not always point only to a developmental or behavioral disorder. It may also mean that the brain's energy buffering system is not working properly. The 10th is adenylosuccinate lyase deficiency, or ADSL deficiency. This is a disorder of purine metabolism. It can affect brain function and may cause encephalopathy, psychomotor developmental delay, intellectual disability, epilepsy, and autistic-like features. So do not assume that a purine metabolism disorder has nothing to do with autistic-like behavior. When certain metabolic pathways fail, the final pattern may be a combination of developmental problems, behavioral abnormalities, and epilepsy. The 11th group includes folate and one-carbon metabolism disorders. These IEMs cannot be explained by simply saying, the child is low in folate. They may cause cerebral folate deficiency, elevated homocysteine, abnormal availability of methionine and S-adenosylmethionine, or SAM, impaired methylation, and disruption of myelin and neurotransmitter function. These children may develop developmental delay, language regression, epilepsy, behavioral abnormalities, psychiatric symptoms, or even autistic-like features. One classic example is FOLR, one-related, cerebral folate transport deficiency, or FOLR1CFTD. The problem is not that there is no folate in the blood. The problem is that folate cannot be transported effectively into the brain. Without treatment, a child may develop developmental delay, cognitive decline, behavioral problems, epilepsy, movement disorders, and autistic-like features. Early treatment with folinic acid, also known as leucovorin, may improve outcomes. Another example is combined methylmalonic acidemia and homocystinuria, cobalamin C-type, or CBLC. This is not simply a folate disorder. It is a disorder of intracellular vitamin B12 processing. As a result, both methylmalonic acid metabolism and the remethylation of homocysteine are disrupted. Late-onset CBLC may present with psychiatric symptoms, ASD features, encephalopathy, epilepsy, peripheral neuropathy, spinal cord disease. It may also involve the kidneys and blood vessels. Another example is 5,10-methylene tetrahydrofolate reductase deficiency, or MTHFR deficiency. The condition can begin anywhere from the newborn period to adulthood. Possible manifestations include developmental delay, epilepsy, intellectual disability, psychiatric symptoms, stroke, or progressive neurologic deterioration. Case reports have also described children who were first diagnosed with ASD or ADHD, but were later found to have MTHFR-related abnormalities. After treatment, some symptoms improved. There are also rarer disorders of folate transport or folate processing. One example is SLC46, a one-related hereditary folate malabsorption, which involves the proton-coupled folate transporter, or PCFT. Another is dihydrofolate reductase deficiency, or DHFR deficiency. These disorders more commonly cause megaloblastic anemia, immune system problems, recurrent infections, epilepsy, developmental delay, or severe neurologic symptoms. They do not necessarily begin with a classic ASD presentation, but clinically, a child with language delay, developmental delay, epilepsy, and behavioral abnormalities may still be placed within an autistic-like or developmental disorder framework. One point must be made very clear. Folate is not a universal key for treating autism. Autistic-like features alone are not a reason to begin folate supplementation blindly. The key is to identify the specific IEM. For example, FOLR1-CFTD, CBLC, MTHFR deficiency, hereditary folate malabsorption, or DHFR deficiency. In these disorders, abnormal folate and one-carbon metabolism can genuinely contribute to autistic-like features, epilepsy, developmental regression, or psychiatric and behavioral abnormalities. But treatment cannot be based on guesswork. Doctors need evidence. That evidence may include plasma homocysteine, methionine, methylmalonic acid, folate measurements in blood and CSF, CSF 5-methyltetrahydrofolate, or 5-MTHF, and genetic testing. The first step is to identify the specific underlying cause. Only then can doctors decide whether to use folinic acid, also known as leucovorin, 5-MTHF, vitamin B12, betaine, or another disease-specific treatment. Chapter 4. When a child with autism also has migraine, do not dismiss it as just a behavioral problem. If inborn errors of metabolism, or IEMs, can destabilize brain networks, then migraine and epilepsy are two very important warning signals. Many people do not realize that children with autism can also have migraine, but migraine is easier to miss in these children, because many of them cannot describe what they feel. A child who can communicate may say, "My head hurts, my eyes hurt, I feel like I might throw up. Light bothers me. Sound bothers me." But a child with more severe autism spectrum disorder, or ASD, intellectual disability, or no spoken language, may not be able to say, "I am in pain." Instead, their pain may take a very different form: self-injury, aggression, irritability, withdrawal, crying or screaming, head-banging, hand-biting. So when a child's behavior suddenly changes, the first reaction should not always be, "They are acting up again. They are refusing to listen. They are having another meltdown." Ask one more question. Could this child be in pain? Part 1. Migraine in children with autism often does not begin with the words, "My head hurts." Pediatric migraine may cause recurrent attacks of moderate to severe headache. It may also involve nausea, vomiting, sensitivity to light, sensitivity to sound, dizziness, blurred vision, abdominal pain, and exhaustion after the attack. Migraine attacks in children may be shorter than attacks in adults. It is also common for a child to feel much better after sleeping. But in a child with autism, migraine may look completely different. The child may not say that their head hurts. Instead, they may repeatedly press their temples, their forehead, around their eye sockets, the bridge of their nose, or the back of their head. They may repeatedly hit their head, bang their head, or press the top of their head against a wall. They may suddenly turn off the lights, close the curtains, refuse to look at a screen, crawl under a blanket, hide in a corner, hide under a table, or search for somewhere dark and quiet. They may bury their head in a pillow, in the couch, or against a parent's chest. They may also bite their hands, the web of skin between the thumb and index finger, their shirt collar, a pillow, or a cord. Sometimes these behaviors are not the child acting out. The child may be using deep pressure or oral sensory input to cope with pain, anxiety, nausea, or sensory overload. There is another situation that is very easy to misunderstand. A child suddenly becomes extremely irritable. They cry or scream. They become aggressive. They hurt themselves. Then they fall asleep. And when they wake up, it is as if nothing happened. After a migraine attack ends, some children may briefly become quiet and relaxed. They may even appear to be in a better mood. If we look only through the lens of autism, these behaviors may be labeled as an emotional problem, repetitive behavior, sensory-seeking behavior, or challenging behavior. But parents and doctors need to ask one more question. Could this be a headache, dental pain, ear pain, migraine? Could this be the period before or after a seizure? Could it be a medication adverse effect? Or could an IEM be suddenly destabilizing the child's brain networks? Of course, headbanging does not automatically mean migraine. Migraine must be evaluated by looking at the pattern of attacks. But headbanging, hand-biting, and hitting the head may be the child's way of communicating pain. Part 2. Squinting, forceful blinking, and facial grimacing can sometimes look like tics. Around a suspected migraine attack, some children with autism may develop frequent squinting, forcefully squeezing their eyes shut, wrinkling their nose, pulling their mouth to one side, stretching their mouth into a grin, making unusual facial expressions, rubbing their eyes, pressing around their eye sockets, tilting their head, lowering their head, closing their eyes, or eye movements that look unusual. These signs are worth documenting, but they are not enough on their own to diagnose migraine. There are several possible explanations. First, the child may be experiencing sensitivity to light or visual discomfort. Migraine aura can cause flashes of light, bright spots, zigzag lines, blind spots, blurred vision. It may also cause tingling or numbness or difficulty with speech and language. A typical migraine aura usually develops gradually. It is reversible, and each individual symptom generally lasts no longer than 1 hour. Second, the child may be squinting, closing their eyes, or lowering their head to reduce exposure to light. During a migraine attack, bright light can be extremely uncomfortable. Third, the cause may be an eye problem, nearsightedness, astigmatism, strabismus, dry eye, corneal irritation, or inflammation of the eye. These conditions may also cause a child to rub, squint, or squeeze their eyes shut. Fourth, the child may have a true tic. Tics commonly include blinking, wrinkling the nose, facial grimacing, or throat clearing. The movements are usually brief, repetitive, and stereotyped, but they are not necessarily accompanied by nausea, vomiting, sensitivity to light, sleepiness, or improvement after sleep. Fifth, the movements may be related to epilepsy or a medication adverse effect. Certain focal seizures, eyelid myoclonia, absence seizures, forced eye deviation, or an acute dystonic reaction can all resemble forceful blinking, facial grimacing, or tic-like movements. So, when a child with autism develops squinting, forceful blinking, facial grimacing, or unusual eye movements, the cause could be a migraine-related visual aura. It could be sensitivity to light, eye pain, or sensory overload. But it could also be a tic, epilepsy, an eye disorder, or a medication adverse effect. One movement alone is not enough to reach a conclusion. The evaluation must consider the pattern of the episodes, the accompanying symptoms, an ophthalmologic examination, an electroencephalogram or EEG, and the timeline of medication use. Part 3. Sensory sensitivity is one of the places where autism and migraine overlap. Autism and migraine have one major feature in common. Many people with either condition are highly sensitive to outside stimulation. Bright lights, flickering screens, intense sunlight, loud noise, high-pitched sounds, strong odors, crowded environments, the texture of clothing, or sudden changes in tactile stimulation. Any of these may push a child with autism into sensory overload. People with migraine also commonly experience sensitivity to light, sensitivity to sound, sensitivity to odors, sensitivity to movement, nausea, and fatigue. So when a child with autism suddenly becomes irritable, bangs their head, covers their ears, squints, hides from light, or begins crying, do not rush to say they are not listening. They are having a meltdown. The child may be experiencing sensory overload. They may be having a migraine attack. The migraine may be amplifying their sensory system even further, or sensory stimulation may have triggered the migraine. And because the child cannot explain what is happening, the only visible response may be their behavior. At that point, families and schools can try several simple measures. In a bright environment, the child may wear a hat or sunglasses. In a noisy environment, noise-canceling headphones may help. Strong odors should be avoided when possible. During an attack, the child may rest in a quiet, dimly lit, low-stimulation space. This is not spoiling the child. It is also helping doctors determine, is this difficulty with sensory regulation? Is this a migraine attack? Or are both happening at the same time? Part 4. Headaches in children with autism are not limited to migraine. Doctors may also need to distinguish among tension-type headache, a sinus-like headache, vestibular migraine, abdominal migraine, and the less common but extremely painful cluster headache, or CH. First, let us look at migraine. Migraine often causes recurrent attacks of moderate to severe pain. It may be accompanied by nausea, vomiting, sensitivity to light, sensitivity to sound, dizziness, blurred vision, and abdominal pain. But a child with autism may not describe it that way. Instead, the child may hide from light, cover their ears, hit their head, bang their head, press around the eye sockets or the bridge of the nose, bite their hands, refuse food, cry or scream, become extremely sleepy, and feel much better after waking from sleep. Pediatric migraine is diagnosed primarily through the medical history, the pattern of the attacks, and a neurologic examination. It cannot be confirmed by one laboratory test. Next, there is migraine with aura. Before the headache begins, some children develop visual or sensory changes. These may include flashes of light, bright spots, zigzag lines, blind spots, visual distortion, tingling in the hands or face, or difficulty with language. A child with autism may not be able to say, "I see flashing lights." Instead, the child may suddenly squint, rub their eyes, squeeze their eyes shut, stare at one spot, hide from light, cover their eyes, move closer to objects to look at them, or suddenly become irritable and bang their head. Then there is tension-type headache. This may feel like a tight band wrapped around the head. The pain is usually on both sides. It feels pressing or tightening. It is generally mild to moderate. Routine physical activity usually does not make it significantly worse, and it does not usually cause prominent nausea or vomiting. Children with ASD may develop tension-type headaches in association with anxiety, poor sleep, long periods of screen use, posture problems, tension in the neck and shoulders, teeth grinding, or sensory stress. They may rub their forehead, rub their temples, hold their neck stiffly, raise or shrug their shoulders, or avoid physical activity, but they may not vomit. Some children improve with relaxation, rest, or a warm compress. Then there is what people often call a sinus headache. More accurately, it may be migraine mistaken for sinusitis. Many people believe their headache comes from a sinus infection, but the pain may actually come from migraine. Migraine can also cause facial pressure, nasal congestion, and clear nasal drainage. These symptoms may look like a sinus problem, but they may reflect autonomic nervous system involvement during a migraine attack. A headache caused by true sinusitis is more likely to occur with signs of infection. Fever, thick or discolored nasal discharge, a reduced sense of smell, persistent nasal congestion, cough, or pain in the upper teeth. These two conditions should not be confused. Next is vestibular migraine. Some children with migraine may not report head pain. Instead, they may develop vertigo, unsteady walking, worsening motion sickness, fear of spinning, a sudden fear of going up or down stairs, nausea, vomiting, or difficulty with spatial orientation. Children with ASD may already have differences in vestibular sensory processing, so vestibular migraine can easily be mistaken for a sensory processing problem. If the vertigo occurs in distinct episodes and is accompanied by sensitivity to light, sensitivity to sound, nausea, headache, a family history of migraine, or marked fatigue after the episode, it should be discussed with the child's doctor. Then there is abdominal migraine. For some children, the migraine pattern does not begin in the head. Instead, they develop recurrent attacks of moderate to severe abdominal pain. The pain may be accompanied by nausea, vomiting, and pale skin. An attack may last from 2 to 72 hours. Between attacks, the child returns to normal. If a child with ASD repeatedly shows abdominal pain behaviors, such as curling up, refusing food, vomiting, turning pale, sweating, rubbing their eyes, yawning, fatigue, loss of appetite, crying, or improvement after sleep, the differential diagnosis should include abdominal migraine, gastrointestinal disease, constipation, food intolerance, and metabolic disorders. Finally, there is a rare headache disorder that should not be missed: cluster headache, or CH. Cluster headache is not a type of migraine. It belongs to a group called trigeminal autonomic cephalalgias, or TACE. CAH is uncommon in children, but its features are very distinctive. The pain is strictly one-sided. It usually occurs around the eye, above the eye, or in the temple. The pain is extremely severe. On the same side as the pain, the child may also develop tearing, a red eye, nasal congestion, a runny nose, eyelid swelling, forehead or facial sweating, a constricted pupil, or a drooping eyelid. Another important feature is marked restlessness. The child may not lie still quietly. Instead, they may pace back and forth. They may appear restless and agitated. Each attack usually lasts from 15 to 180 minutes. The frequency may range from one attack every other day to as many as 8 attacks per day. The attacks also often follow a recognizable rhythm. They may occur at night, they may begin at roughly the same time each day, and they may occur in clusters for several weeks, a period known as a cluster period. So if a child with autism has headache-like attacks that clearly favor one side, if the child always holds the same eye, the same temple, or the same side of the face, if the attacks begin suddenly and end suddenly, if each attack lasts about 15 minutes to 3 hours, if several attacks can occur in one day, if they appear in clusters for several weeks, followed by a long period of relief, if the attacks also involve a red eye, tearing, nasal congestion, a runny nose, eyelid swelling, facial sweating, or a drooping eyelid on the same side, and if the child is markedly restless during the attack, then parents should discuss with the child's doctor whether this could be CH or another TAC. There are also headache warning signs that require prompt medical attention. A child's first severe headache, a sudden, explosive, thunderclap-like headache, a headache that is progressively worsening, a morning headache with vomiting, a headache that wakes the child during the night, fever and neck stiffness, altered consciousness, a seizure, weakness on one side of the body, abnormal walking, changes in vision, a recent head injury, or papilledema found during a medical examination. If any of these occur, seek medical care promptly. In a child with headache, doctors must first rule out infection, elevated intracranial pressure, bleeding, a tumor, a vascular abnormality, and other neurologic disorders. Part 5. A headache does not always have just one cause. People with autism commonly also experience anxiety, depression, sleep disorders, attention deficit/hyperactivity disorder, or ADHD, epilepsy, gastrointestinal problems, and differences in sensory processing. These conditions themselves may increase the risk of headaches and migraine. Too little sleep can trigger migraine. So can fragmented sleep. Anxiety and stress can increase sensitivity to pain. Gastrointestinal problems, dehydration, vomiting, constipation, and inadequate food intake can also make headaches more likely. Medications must also be considered. Medications used for anxiety, depression, epilepsy, sleep problems, ADHD, or behavioral problems may sometimes affect headaches, sleep, appetite, level of consciousness, liver function, or neuronal excitability. If a child develops new symptoms after starting a medication, switching medications, or increasing the dose, parents should tell the doctor exactly when the changes occurred. These symptoms may include significant headaches, excessive sleepiness, irritability, worsening mental status, vomiting, abnormal muscle tone, abnormal liver test results, or a sudden worsening of behavior. The doctor then needs to reassess the situation. Is this the underlying disorder? Is it migraine, epilepsy, a medication adverse effect? Or is an underlying IEM making the child less able to tolerate the medication? This does not mean that medications cannot be used. The key is to look for clues about the cause before treatment begins, and after a medication is started, watch the pattern of the child's response. Chapter 5. Why should migraine and epilepsy be considered together? Migraine and epilepsy are not the same diagnosis, but they have something important in common. Both are episodic disorders of brain networks. Epilepsy involves abnormal electrical discharges from neurons, but seizures do not always look like convulsions. They may appear as brief staring spells, unusual sensations, smelling an odor that is not actually there, sudden fear, a pause in behavior. repetitive automatic behaviors known as automatisms, or unusual movements during sleep. Migraine, especially migraine with aura, is associated with cortical spreading depression, or CSD, neuronal excitability, glial cells, blood vessels, and pain processing networks. Migraine and epilepsy may both involve potassium ions, the sodium-potassium pump, glutamate, gamma-aminobutyric acid, or GABA, mitochondrial function, and the overall stability of brain networks. That is why their attack patterns, clinical features, and underlying mechanisms can sometimes overlap. This also explains several situations seen in clinical practice. A migraine aura may be mistaken for an epileptic seizure. Migraine aura usually develops gradually. It typically lasts from 5 to 60 minutes, and it is reversible. An epileptic aura is usually shorter. It tends to begin more suddenly, and it may be accompanied by a change in awareness or automatisms. Some children develop a throbbing headache after a seizure. Others develop a migraine-like headache. And some children have both migraine and epilepsy. But there is an even more important connection. Some inborn errors of metabolism, or IEMs, can cause several of these features at the same time. Recurrent headaches, migraine-like attacks, epilepsy, vomiting, stroke-like episodes, learning difficulties, movement abnormalities, and psychiatric or behavioral symptoms. One classic example is mitochondrial disease, especially mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, or MELAS, if a child or adult has recurrent headaches, repeated vomiting, epilepsy, stroke-like episodes, diabetes, exercise intolerance, hearing loss, or a maternal family history of similar problems, the level of concern should rise. Urea cycle disorders, or UCDs, are another example, especially late-onset ornithine transcarbamylase deficiency, or OTC deficiency. It may cause headaches, vomiting, an aversion to protein, epilepsy, delirium, behavioral abnormalities, or a reduced level of consciousness, infection, fasting, a high protein intake, surgery, childbirth, or certain medications may trigger hyperammonemia. Glucose transporter type 1 deficiency syndrome, or GLUT1DS, can also cause hemiplegic migraine-like episodes in rare cases. These patients often also have epilepsy, ataxia, or developmental problems. Fabry disease may also cause headaches or migraine-like symptoms, but if those headaches occur together with burning pain in the hands and feet, reduced sweating, angiokeratomas, kidney involvement, heart disease, or cerebrovascular findings, the symptoms should not be treated as ordinary migraine alone. Migraine has also been reported in glutaric acidemia type 1, or GA1. GA1 should be considered further when migraine occurs together with macrocephaly, developmental regression, dystonia, pyramidal signs, characteristic white matter or frontotemporal abnormalities on brain imaging, or encephalopathy after catabolic stress, such as infection or fasting. There are also case reports of L2-hydroxyglutaric aciduria, or L2HGA, presenting with migraine, as well as cases involving severe autistic features. Some patients with late-onset UCDs, mitochondrial disorders, or GLUT1DS, may also have autistic features. So, when a child with autism has both migraine-like symptoms and epilepsy, do not view them only as separate coexisting labels. Chapter 6. When should an IEM be included in the differential diagnosis for a child with autism? First, not every autistic-like presentation should automatically be attributed to an inherited metabolic disorder. And not every behavioral problem should immediately raise suspicion of an IEM when they occur in isolation. Migraine, an abnormal electroencephalogram, or EEG, and epilepsy are all relatively common. By themselves, they usually do not substantially increase the likelihood of identifying an IEM. What carries greater diagnostic value is a combination of regression or fluctuation, acute encephalopathy, triggers for metabolic decompensation, movement abnormalities, organ involvement, distinctive clinical findings, and abnormal laboratory results. Clinically, doctors must first consider other acquired causes, trauma, infection, tumors, medications, toxins. These possibilities must be evaluated first, but if they do not fully explain the symptoms and the child shows one of the following red flag patterns, the level of concern should rise. These red flags are not diagnostic criteria. They are clues that change the pretest probability and help determine whether further testing is justified. The first red flag is regression. The child's development is not simply progressing slowly. The child is losing previously acquired abilities. Words the child once used suddenly become fewer. Skills the child once had suddenly disappear. Movements the child could once perform are no longer possible. Losing an acquired skill deserves more attention than development that is simply delayed. The second red flag is fluctuation. The symptoms are not always the same. They come and go. Sometimes the child seems better. Then the child suddenly becomes worse. It is as if the brain keeps dropping offline. The third red flag is a consistent trigger for each deterioration. Fever, infection, fasting, vomiting, exercise, menstruation, surgery, anesthesia, or certain medications. If the child's language, behavior, level of awareness, gait, or seizures consistently worsen after one of these events, this is more than an ordinary bad mood. The fourth red flag is a behavioral episode that occurs together with physical or neurologic signs. Migraine, vomiting, excessive sleepiness, epilepsy, fluctuating awareness, unsteady walking, abnormal eye movements, or extreme fatigue after the episode. In that situation, the behavior may be only the surface presentation. The real problem may lie within the brain network itself. The fifth red flag is drug-resistant epilepsy, absent seizures, an abnormal EEG, or an unusually long recovery after a seizure. All of these require further medical evaluation. The sixth red flag is a movement abnormality, low muscle tone, dystonia, choreiform movements, ataxia, or a worsening gait. If the child is not only behaving differently, but also showing changes in movement or physical abilities, greater caution is needed. The seventh red flag is evidence that multiple body systems are involved. Hearing loss, vision problems, a skin rash, hair loss, coarse facial features, an enlarged liver or spleen, recurrent infections, chronic diarrhea, exercise intolerance, hypoglycemia, elevated lactate, elevated ammonia, or metabolic acidosis. These findings suggest that the problem may not be limited to the brain. It may be affecting metabolism throughout the body. The eighth red flag is a distinctive family history. Epilepsy, psychotic-like episodes, intellectual disability, sudden infant death, or a maternal family history that includes a combination of migraine, hearing loss, diabetes, and stroke-like episodes. All of these details are worth sharing with the doctor. When these red flag patterns appear, do not keep circling around the same few labels. Autism spectrum disorder, or ASD, attention deficit/hyperactivity disorder, or ADHD, an emotional problem, a behavioral problem. Some symptoms may appear to be scattered and unrelated, but they may actually be the same metabolic pathway sending alarms through different brain networks. IEMs can affect the brain in several ways. The brain may not receive enough fuel. Toxic metabolites may accumulate. Neurotransmitter synthesis may become abnormal. The body may not use essential cofactors properly. Myelin and brain network connections may be damaged. And the final presentation may look like autistic features, ADHD-like features, psychiatric or behavioral symptoms, migraine, or epilepsy. When these red flags appear, parents can ask the doctor whether a tiered metabolic and genetic evaluation may be appropriate. This does not mean that every possible test must be ordered at once. The goal is to follow the child's symptoms and look for clues one step at a time. Testing may include blood glucose, blood gas analysis, electrolytes, liver and kidney function tests, lactate, ammonia, urine ketones, plasma amino acid analysis, an acyl-carnitine profile, urine organic acid analysis, homocysteine, vitamin B12 and folate, and creatine kinase, or CK. When clinically indicated, the evaluation may also include brain magnetic resonance imaging, or MRI, magnetic resonance spectroscopy, or MRS, and EEG, metabolite testing in cerebrospinal fluid, or CSF, and genetic testing. One point is important: screening tests only point toward a possible direction. A diagnosis usually cannot be established from a single result. Doctors need to interpret the biochemical findings, enzyme studies, brain imaging, genetic findings, and the child's actual clinical presentation as one complete picture. Metabolic and genomic testing are still evolving. In non-syndromic ASD, routine metabolic screening has not been shown to identify IEMs at a rate higher than that seen in the general population. For that reason, comprehensive metabolic testing is not recommended for every person with ASD who has no red flag pattern. But one warning must not be overlooked. Isolated psychiatric or behavioral symptoms do not rule out an IEM. Some late-onset IEMs may first appear as depression, psychosis, attention problems, behavioral changes, or cognitive decline. The physical signs may not appear until later. Chapter 7. The most valuable thing a parent can do is not try to diagnose an IEM alone. It is to document the pattern. Many times, what the doctor needs most is not simply the statement, "My child had another meltdown today." The doctor needs a more specific timeline. When did the episode begin? What happened beforehand? What happened during the episode? And how did the child recover afterward? These details can be extremely important. Parents may want to record several categories of information. First, record when each episode occurs: headbanging, hand-biting, crying or screaming, self-injury, aggression, vomiting, excessive sleepiness, headache-like behavior, or a seizure-like episode. Does it often happen early in the morning on an empty stomach? Does it happen around dusk or in the evening? Does it repeatedly occur after a night of poor sleep? Second, record possible triggers before the episode: bright light, noise, secondhand smoke, strong odors, air pollution, sleep deprivation, fever, fasting, a particular food, exercise, a sudden change in the daily schedule, or emotional stress. Third, pay attention to changes in weather and the environment. A change of season, especially the arrival of spring, thunder, lightning, Heavy rain, a major shift in barometric pressure, a sudden drop in temperature, hot weather. Overheating after a hot bath. Overheating after exercise, long-distance travel, air travel, or suddenly traveling to a high-altitude area where oxygen levels may be lower. These changes are not necessarily the cause, but they are worth documenting. Some children's brains and bodies may be especially sensitive to these changes. Fourth, record any symptoms that occur before, during, or after the episode. Hiding from light, covering the ears, redness in one eye, nasal congestion on the same side, tearing, a drooping eyelid, squinting, rubbing the eyes, pale skin, nausea, vomiting, unsteady walking, abnormal eye movements, unusual sleepiness, or repeated yawning. These details may help the doctor distinguish among migraine, epilepsy, an eye problem, an ear, nose, or throat problem, or a metabolic disorder. Fifth, record how the child recovers. Does the child sleep for a long time? Do the symptoms improve significantly after sleep? Does the child briefly seem happier afterward? Do they suddenly become quiet? Does it look as though the child has rebooted? Sixth, record any loss of previously acquired abilities. Has the child begun using less language? Has learning declined? Has physical ability worsened? Has social functioning changed? All of these changes should be documented. Seventh, keep a medication timeline. Was a new medication started? Was one medication replaced with another? Was the dose increased? Was a medication stopped? After one of these changes, did the child develop headaches, excessive sleepiness, irritability, vomiting, worsening awareness, abnormal muscle tone, or a sudden worsening of behavior? This information can be crucial when doctors are evaluating a medication adverse effect or an underlying metabolic problem. These records can help the doctor distinguish a behavior related to ASD, migraine, epilepsy, a medication adverse effect, a sleep problem, a gastrointestinal problem, an eye problem, an ear, nose, or throat problem, or a metabolic disturbance of brain function that may require further evaluation for an IEM. One more point must be made clear. Recording possible triggers does not mean turning every trigger into an absolute prohibition. It does not mean that every child with autism must avoid exercise, never leave the house, never look at a screen, never take a hot shower, or never enter a crowded environment. That is not the goal. The purpose of recording is to find a pattern and to identify triggers that may be adjusted. If episodes repeatedly occur after too little sleep, then sleep management becomes a priority. If the child repeatedly becomes overwhelmed in a shopping mall, a movie theater, a vehicle or public transportation, or a brightly lit classroom, then light, sound, odors, and crowd density all deserve closer attention. If headache-like episodes repeatedly occur after exposure to a flickering screen, then that screen exposure is worth documenting carefully. Conclusion: the child is not losing control on purpose. Sometimes the brain is calling for help. Autism, migraine, epilepsy, and psychiatric or behavioral abnormalities can occur independently. They can also occur as coexisting conditions. But in some people with IEMs, they may be different footprints left by the same metabolic imbalance inside the brain. Migraine may be the pain network sounding an alarm. Epilepsy may reflect a loss of control over neuronal excitability. Depression and psychiatric symptoms may be related to disruption of the frontal lobes, the limbic system, neurotransmitters, or energy metabolism. Autistic-like features may reflect the long-term effects of genetic, metabolic or neurobiological factors on brain networks that are still developing. Emotional outbursts, aggression, self-injury, hallucinations, and severe sleep disruption may also be outward signs of an imbalance involving brain energy, neurotransmitters, amino acids, essential cofactors, or toxic metabolites. So when a child's symptoms appear suddenly, repeatedly fluctuate, or are triggered by infection, fasting, exercise, or medication, when they occur together with developmental regression, epilepsy, migraine, vomiting, excessive sleepiness, fluctuating awareness, movement abnormalities, or involvement of multiple body systems, and when there is also abnormal ammonia or lactate, hypoglycemia, acidosis, or a distinctive family history, then an inborn error of metabolism should be included in the differential diagnosis. Psychiatric symptoms are not sufficient evidence of an IEM. Autistic-like features are not sufficient evidence of an IEM either, but in some children they may be the earliest signs that an IEM allows us to see. Recognizing those signs earlier may spare a family years of wrong turns. For some treatable inherited metabolic disorders, finding the cause earlier does more than give the condition a new name. It may change the emergency plan. It may change medication choices. It may change dietary management. It may change the direction of rehabilitation. It may change family screening. And it may change the assessment of recurrence risk in future pregnancies. More importantly, it may change how a family understands the child. The child is not losing control on purpose, and it may not be just a behavioral problem. Some children's brain networks may be disrupted by pain, epilepsy, sleep problems, medications, or an underlying metabolic disorder. When we learn to understand these signals, the child receives more than another label. The family receives an explanation that moves closer to the truth and help with a clearer direction. So, when a child with autism has both migraine-like symptoms and epilepsy, do not view them only as two coexisting labels. Keep asking, could there be a shared instability in the brain's networks? Could there be a shared genetic or metabolic cause? Because in some children, headaches, epilepsy, vomiting, behavioral loss of control, and developmental regression may look like separate problems. But beneath the surface, the same metabolic pathway may be sounding the alarm again and again.